So there are numerous unmet needs that we encounter in clinical practice: patient adherence, treatment complexity, psychosocial distress, the diagnosis of depression, assessing whether the patient has cardiovascular risk or not. And we have medications, a variety of medications. I would say an explosion of medications over the last several years, some with limited glycemic lowering, some with durability and safety and tolerability concerns. Cost is always a concern when we're trying to manage patients. There are now agents with variable effects on cardiovascular risk, and the question is, does that just apply to the patients who have known cardiovascular disease, or is that going to also apply to the patients at high cardiovascular risk? Because we still have some clinical trials that have yet to report out that may inform us on this. And of course, we have dosing and administration limitations to some of these agents. We know that there's a progressive loss of beta cell function over the duration of type 2 diabetes. I think it's an important topic to discuss with patients so they don't feel like just because I need a new medication means that somehow I personally as a patient have failed. And we talk a lot about the role of basal insulin and the intensification of basal insulin with GLP-1 receptor agonists. And I think that that is going to be something that becomes increasingly popular as more data comes in and as we get more experience using these in the marketplace. And I think there's also some benefits with early insulin administration. Sometimes there are patients who truly need insulin, and it doesn't always need to be seen as, quote, the last resort, end quote.
Yeah, and basal insulin and GLP-1 receptor agonists have different and complementary mechanisms of actions that result in improvement in both fasting and postprandial glucose control. Clinical trials have demonstrated the efficacy of a basal insulin GLP-1 receptor combination in the management of type 2 diabetes. Now we have fixed ratio combinations of these two agents that allow greater ease of use of a basal insulin GLP-1 receptor combination in one injection. Addressing patient concerns about injections and discussing the efficacy of combination insulin and GLP-1 receptor agonist therapy can help mitigate barriers to injectable treatments for type 2 diabetes.
It's interesting, Vivian, when I started practice, I had glipizide, glyburide, NPH, and regular. That was the sum total of our armamentarium, and it's almost an embarrassment of riches now that we have all of these new medications, but despite that, we still have adherence issues, we still have cost issues and formulary and availability issues. So I'm looking forward to the day when we can sort of make our clinical decisions and try to minimize at least some of those barriers to choosing the right patient and the right medication.